Aneesh,
Good to see you, my friend.
I told you we were going to do this.
This is
7
exciting.
years ago.
You are scaling beyond expectations. Congratulations. And to the family of Startup Health, all of us. It's great to see this movement scale. And thank you for your leadership in making that happen. To Steve, come on, man.
Oh, it's really, it's incredible. I really mean this. It was really fascinating back in 2010 to watch both of you bring the energy to the government, which prior to that, obviously, not only did it not exist, but your role didn't exist. I want to set the stage for what the world was like in health innovation and entrepreneurship in 2010 to contrast that with where we are today. Can you both give us your own perspective on that?
Well, yeah, and what I'll tell you is that there were sort of three, we felt, missing ingredients to really catalyze the ecosystem. And on the tech side of things, we felt that the most powerful data assets in the healthcare delivery system were literally locked up and hidden from public view. So if you were to follow the folks who, interested in healthcare data, the Medicare database, the patients who see a hospital, go to a doctor's office, get a prescription drug filled, they have their information stored for 40 plus million Americans in a database that could tell you so much about waste and inefficiency and opportunity for improvement. But for the most part, unless you were a super secret academic with special keys, you couldn't get access to this information to mine it to find those opportunities. So we had closed up a lot of the databases that the government itself had access to. We didn't really have electronic health records infrastructure, but for Farzad experiment in New York, where we had a sort of an oasis of greatness in a community, we had still manila folders by and large throughout the country. So we didn't have the power of unlocking the value of the information that was held in the clinician's hands. And then last but not least, we had an incentive system, a reimbursement structure that didn't really reward rooting out that waste and inefficiency. So if you think about the active ingredients or the conditions at that time, we had a fairly significant breadth of things to do on policy and technology. And I think the goal was to kind of tackle them. And I'll let Farzad run deep.
Well, I'll give a good example of this. Right before I joined the Office of National Coordinator in June of 2009, I had to call David Blumenthal and say I'm going to be late because my mom's in the hospital and I have to stay here because she's had bleeding complication, infectious complication, cardiac complication. And just if you think about that, she went in for a routine knee replacement. Anyone here had a loved one get a knee replacement? Right? At that time, I was a total data wonk. I could not get data on who does a lot of knees in Boston and what their complication rate is. So we couldn't use data to pick, right? That Medicare claims data would have been awfully helpful to being able to do the sort of benchmarking, quality scorecarding that there's lots of companies now doing and making available. 2, she had the complications. I wanted to look at her chart. Anyone here asked to look at their chart in a hospital?
What? Who are you? Why are you asking for this?
Right? And when I finally screwed up my courage to get it, I couldn't read the handwriting of the cardiologist. Right? And that chart, that gray thing there, it was rivalrous. If I had it, the nurse didn't have it. Right? We couldn't both look at the same damn thing. Right? That's changed now. We went from 9% of hospitals having electronic health records to 99% pretty much. That's a big change. And then the third thing that happened was she had all these complications. They didn't have systems in place. They didn't have the protocols in place. They didn't have the attention to prevent this sort of stuff. Did the hospital get penalized for this poor quality and complications, or did they make more money because they screwed up the care of my mom? They made more money, right? And that has changed. And now we have the readmission penalties, we have quality, we have value-based movement. It's still not enough. But in terms of those 3 key domains that Aneesh laid out, right? Data, is it just oxygen, right? All you can't breathe without the oxygen, right? The data is there, right? Now, both on the public side and on the clinical side. And the business model, which is the fuel. Right? You can't make a business without a new business model. If the business model is just churning people through fee-for-service, yeah, there's some businesses that you can do there, but nothing that interesting and new. And there's now, I bet a whole bunch of you are now thinking about businesses that actually say, can we make money by having people have fewer bad shit happen to them rather than more bad shit happen to them?
So,
That's a technical term.
I mean, I think what you guys, can we give a round of applause for what these guys did back then? Sounds very obvious now, but give us a little taste of what was happening backstage. So we both saw you on front stage, on stage, talking about the importance of it all around the country. But what was happening backstage then? And I want to illuminate this a little bit, because I think what people don't understand is how much progress has been made, and why we should be so hopeful about where we are today. And when we look back, I talked about this yesterday, there's been over $40 billion over the past 7 years invested in digital health and health innovation now. It was $1 billion in 2010. It's now $40 billion combined, $11 billion this year. But what was happening backstage to enable and unlock the data you're talking about?
Well, I'll let Farzad share a perspective on his side. Let me give you my take. There are two Washingtons, okay? There's the Washington that we see in the cable news shows that is, you can eat popcorn today because it's sort of entertaining but depressing or expiring depending where you are on the spectrum. It is a sort of everyone hates each other, battle royale, fight to the death, who's up, who's down. That's what is perceived, and I acknowledge that there is a great deal of that still in aspects of Washington. The agenda that we just described, the shift from closed to open on data, the migration of medical records from manila folders to electronic folders that can talk to each other, and the shift in payment to reward value, that's part of the quiet Washington, where people on both sides of the aisle actually want to sit together and make things work. But they don't want to say it too loudly, because then it's a partisan thing where if you're for it, then someone has to be against it. So let's get people in the room and talking about the things that need to be done that are enabling ingredients for whether you're a partisan on the left or a partisan on the right, you can still see the benefits of this activity. So the story about behind the scenes is what I'll share with you, and you can see manifest in the world today. There is a growing consensus among those who are in Washington on both sides of the aisle that this is a multi-generational play to make the country a better place. Steve, I'll make one observation. And this is going to be a bit of an exaggeration, but just take it for what it's worth. If the country gets the growth rate of healthcare inflation to GDP plus 0, we have enough money left over to pay for tax cuts for the rich, if that's your thing, or expanded social safety net, if that's your thing, that's my thing, or wherever you are in the spectrum, we will be as a country stronger and more competitive globally if we can retain the growth rate of the healthcare sector to GDP plus 0. So we can have a partisan fight about what to do with the winnings if we achieve this goal relative to the budget, but we have a unified goal that if we can achieve more value at GDP plus 0, that is the victory for everyone. And I'll let Farzad describe maybe on the electronic health record side a similar but maybe related story. But I would say that is the theory, and that backstage discussion you're mentioning has extended. Even in the Trump administration, there are extremely talented people in the Trump administration who are carrying forward these very principles. You're going to hear from one momentarily. Bruce Greenstein is a brother in arms in this movement. I don't know what his D or R label is in the back, and I don't care, because he's carrying the ball forward, building on progress, and you're seeing that and you're going to hear from him directly. So good news and love from me. You'll hear directly and judge for yourself. But that's the back room as I saw it, Steve.
That's great. Thanks.
So it's a little bit like it was a startup that just got, like at ONC, we got $2 billion of grant funding as a startup. So imagine being
what was the budget? What was the budget prior to the funding?
It was like $60 million.
Right.
So we're from 60 million to 2 billion.
2 billion. So imagine, right, like you're a startup and you just did a $2 billion round. And then it's like, well, what can you do? And if you're a startup that just got $2 billion, you think you can do everything, right? And that was a little bit of the feeling, right? Like, well, why don't we do, let me see, everything. Let's just do everything, right? Let's do everything. And when you're now a 6-7-year-old company, and now you're in your E round or whatever, and you have a product now, and now you can't mess around with doing too many crazy things, right? Now you got a few things that you got to do really well. And I think that's a little bit of perhaps what you're going to see now is a lot more, what do I think about those early days? I smile and cry a little bit about how naive we were, just as you would be as a startup, right? With that you could do all these crazy things, right?
As you should have been, quite frankly. From the perspective of an entrepreneur, you're supposed to think things that are unconventional and think you can do it all and have confidence and ambition.
I know. But then you're looking back, you're like, God, if we had just not done the 80% of the stuff that didn't pan out, right? And it's always like as a startup, you're like, yeah, if we'd only done the 20% of stuff that had panned out. I'm like, well, did you? Right? But I do think that right now, it's actually like my successor now at the Office of National Coordinator, he's got a lot more of a focused agenda now, right? Because the work is much more clear, no less important though. And I think to Aneesh's point, we've made a lot of progress, but I don't know, on some of the stuff we're at the, 60-yard line. Some of the stuff we're at the 90-yard line, they got to punch it through. But the field of play is much more clear now.
So as we bridge from where you were to where you are now, and what you're both doing now, I want to kind of connect the two, which is something you said to me before we came on stage, which is you talk about that startup you had with $2 billion, and you're now at the Series E. Leadership changed, right? And every company knows what that's like, but I think in this government, the headlines are not always necessarily what's happening backstage. I was actually very pleasantly surprised about your confidence about the new leadership in there at the health level and the technology level, and what is really carrying the torch that you both and Todd Park started back then. Can you talk a little bit about, Bruce, of course, we're going to hear from, but just how you're feeling about the torch that's been now handed off and how the next couple of years as it plays out, not in the front stage, but what's backstage on health and why we should.
If we say things too politely, then it may cause.
They're like, oh, maybe they're suspect, these people.
I know. But in all seriousness, break the three components down.
Yep.
Payment reform. So in the Affordable Care Act, the vehicle that was created, or the authority that was created, basically this is a remarkable thing, just to kind of peel the story back a little bit. It used to be the case that doctors had to go to Congress every year and beg for payment policy every single year. Could you imagine having to depend on the act of Congress to decide whether you're going to take an 18% pay cut or break even? I mean, it's just ludicrous. But that was the world, kind of pre-2009. And what I would say to you is that we gave it a first shot in the Affordable Care Act, and then we sort of massively doubled down in MACRA. And this is Farzad's baby, so I'll let him kind of get into that in more detail. But the high level point is Congress ceded the authority to micromanage payment policy to the executive branch of government. What that meant was if the YMCA had a theory that pre-diabetic patients going through a form of boot camp coaching, lifestyle change for 15, 16, whatever weeks, hi Esther, if all of them went through this program and they could avoid going to, that's a 4-to-1 return on investment, Steve. That is worthy of reimbursement. So Congress did not have to pass a new law allowing us to get paid to provide vouchers to the YMCA. We ran effectively a payment trial, and the evidence came back 4-to-1 ROI. Actuary stamped it and said, yep, good to go. So now, 1/1/18, every Medicare patient that's pre-diabetic can have a doctor prescribe the course of YMCA diabetes prevention, and not just YMCA, but anyone in that program. Point being, who will the Trump administration name to lead payment reform policy? There are rumors as to who the person might be, so it's not a formal or official statement, but if the rumors are true, it's someone that is extraordinarily thoughtful and will carry the torch. And that's a gentleman named Adam Bowler. I don't know if he will or he won't, but it's rumored to be. I have no idea. Great guy if it is, and maybe someone like him if it's not him. On the data side, we have Bruce, you're going to hear about in a moment, And he's already announced his agenda, and it's very much building on the progress of continuing to open up more data sets, making it easier for developers to access it. And my presumption is that 90%, up to 10% punching it through, you'll see a lot of activity. And then even at the issue of the EHR side, as Farzad just outlined, scoping down the effort, but being more thoughtful about taking it over the finish line, that is building on progress. So in all three, if they stay as we believe it will happen, it looks as if that will be a nonpartisan moving forward. And maybe some will say faster, slower, better, whatever. Who cares about who gets credit, whatever. It will be in this direction. So that's why I have hope. And I'm sure you might have more detail on your perspective about these policy issues that, in the Affordable Care Act repeal debate, what was missing from the repeal debate, Steve?
All of this.
All of this. Shh. Explain. Why, Farzad?
Yeah. Well, I will add a little flavor to it, though, because in 2012, I was national coordinator, and we were thinking, like, what would happen if President Obama was reelected, as he ultimately was, or if he weren't to be reelected. And after the election, I called together all the heads of the big EHR companies to kind of lay out the agenda for the next 4 years. Like, hey, we're not going away here. You know, keep focused. But I had a conversation with my staff about what would a different national coordinator who came in do if they came from a different political philosophy, and that we should take the opportunity, just as a CEO, like I should always be thinking, if they replaced me, if the board replaced me and brought in a new CEO, what would be obvious to that CEO that we should have been doing all along, right? And why wait until they replace me? Like, let's just go do that, right? It's a pretty good question to ask yourself, right? If the board replaced me, brought in a new CEO, what would they do differently? And so this is an opportunity to look not just at the continuity, and I think, as Aneesh is saying, there's going to be tremendous continuity, but what would be some new ideas that would not have, if there had been, a third Democratic term, would not have been as much front and center in terms of the style or the philosophy that now opens up the field of possibility. And one issue that I think is a good issue that is getting and will get more attention, and there was just a request for information, there was an executive order from the president around this, was around competition. And if you really believe that you want to have market-based approaches, and why do we have to have, like, the regulator always fine-tuning and tweaking things and reacting to the field? Like, why don't we have the magic of markets? You know what markets hate is monopolies, right? And in too much of healthcare, we are seeing consolidation, vertical integration, horizontal integrations, monopolies forming, lack of competition, frankly anti-competitive behavior on the part of incumbents that don't allow startups to be those new entrants into the field, using their market power in one area to stunt your ability to innovate in the other area. You all know what I'm talking about. And that is something that would be very interesting to see a real, true pro-competition policy coming out of this administration that I think will be more muscular than maybe what we would have just naturally thought about. We would have thought, oh, someone's doing this thing, let's regulate that, right? But there may be other things that come into play now.
So fascinating perspective, because I think you both have such a unique perspective given what you've done to now shift to what you are both now not just passionate about, but really continuing to push towards and break through it. Maybe as difficult as it was back then, but push to change.
Yeah.
Can you tell us both what you're doing, tell us all, what each of you are doing now? Because I think it plays into not only what you did, but what a lot of people here need.
So Farzad's story is more widely known. I think it'd be great for him to share how he's doing it. Let me share my perspective, which is a direct link to my prior life. So my theory was that so this magical Medicare linked database, the Part A, Part B, and Part D that can tell you where all the inefficiency was, we went from having no methods of accessing this data to now there are 3 methods of accessing this data. The individual Medicare beneficiary, my mom and dad both on Medicare, My dad saw a doctor August 27th, came to my house at Labor Day weekend. I went to mymedicare.gov. His claims data was already in the IT system, so I could download it and understand it and help make sure that he didn't miss anything. So I felt, okay, path one, make sure the individuals get access. Path two, we created this program.
How many folks here knew that you could do that? mymedicare.gov. You could go online for a senior, and they, with their user ID password, you could look at all the claims paid. Detailed. Line level, diagnosis, provider, biller, how much was paid.
Machine readable format.
How many? Raise your hand.
One.
If you know about that.
We have two. Three. This is a room of healthcare startups. Yeah. Hardly. Yeah. So this is issue number one. He's getting to my punchline, which is the following. The second path was Medicare ACOs. Farzad will describe more. But we took that single patient file, and if you happen to be a panel of patients assigned to a doctor, that doctor gets that bulk file, but it's the same linked ABD file. And the third is innovators and entrepreneurs can apply for a seat where they can take their analytics to the CMS database, even if they can't take the raw data out. You can take your output out, but you can bring your algorithms in, basically. We inverted it. So my point, Steve, is that, wow, look at all the innovation. People are going to be building applications and services that can make the most use of that data. And instead, I saw a lot of, whoa, simple, take the stuff that the insurance companies used to do and just run it on the Medicare claims data and give me my standard, you use the ED too often, or you didn't do this or that. I said, man, that seems like a massive under-leveraging of this data asset. So the company I run, CareJourney, effectively tries to wrangle twice the productivity out of that same data file to make it more clinically relevant to physicians who are on this journey to value-based care. Pretty simple idea. Take the same raw asset, but find more clever ways to say to physicians, this group of patients would benefit from that care model. You might want to prescribe it and measure the impact. And that's a pretty simple idea. And your point about our transition, here we are at the highfalutin level. Policy, you should do this, unlock this, celebrate the data, see what startups do.
Still there, brother.
Still there, all the opportunity. So now I'm like in a narrow sliver of the world where I'm just grabbing that data file and squeezing like an orange every possible source of clinical value and sharing it with the clients that we service, folks that are in that Medicare ACO space, so they can make the most sense of it. And he's, this idea of knowing the policy, knowing the opportunity, frustrated that it wasn't happening for whatever weird reason, and then recruiting a team to go after it.
And so what's the best, before we go into what's the best example of how that's manifested into something that's made impact?
Well, so this is actually one of the most depressing examples. So every doctor knows a sensitive moment in a patient's life is when they transition from the hospital, the nursing home to home. In that transition, something janky may happen in that the patient may not get their medications quite right. They may not get explained the discharge instructions quite right. So there's a desire societally to have someone explain what's supposed to happen early in that discharge so that they can be better cared for over the next 60, 90 days. Well, it turns out CMS says, if you do that, we'll pay you more. But like only 15% of all patients that have an eligible discharge actually have a doctor perform the service.
What percent?
It's like 15, if even that.
15% of the time we do the right thing. 15%.
And this same reality will happen across every dimension of things where you can get paid for doing the right thing, but for whatever reason, the system doesn't know it. One of our clients has a system where if the hospital that owns the practice, the patient discharges, 95% of the time they're doing this stuff. But when the patient discharges from the hospital across the street, they're less than 40% of the time. Same doctor, same staff, same everything, bad information flow, whatever the mechanisms are. So we uncover this sort of frustration and inefficiency, and now the leadership team is trying to sort out how do we get the data that we need to be successful. So it's an example, and the ROI is unbelievable. You could cut your costs 15, 20% against patients that didn't get this service when you look at post 30 days from that moment. So this is an example where uncovering these sorts of, you do the right thing, and just be aware of monitoring how well you've done the right thing in the past is an area of opportunity.
So as Farzad goes, we're going to have microphones for a couple questions after Farzad goes, so just get your questions ready while Mike's around the room.
Yeah.
Farzad.
So I left the administration during the last, let's hope it's the latest government shutdown in October of 2013. I left my badge on the desk and walked out because there was no one to hand it to. And at that moment, I left because I was convinced that we had moved from where you can make the biggest difference being policy to where you can make the biggest difference being implementation and execution on those policies. Every person's journey is going to be different on that. But what I felt was that the center of gravity had shifted outside of, the regulation making to execution and taking advantage of those policies that are theoretically available but are not yet in the market. So one of those opportunities was to deliver better care at lower cost, to make money by saving money, and to do so by using the data and the tools that are now available that weren't available before. So, the way I think about it is there's the oxygen, which is data, right? None of us would be breathing the air in this room if there weren't more digital data available. The fuel that you need to combust it, right, is the payment reform. That's what's going to provide the energy. That's the stored energy, right? These new payment models. And I was like, where's the vessel? Where's the combustion chamber here? Like, where do we squirt some gas in there and some oxygen and then spark it? Like, where does that happen? And for me, the answer was clear. It wasn't actually going to be the hospitals. It was going to be a disruptive, new networks of independence, decentralized folks brought together through technology and brought to scale. And so we started this company called Aledade 3.5 years ago to create physician-led groups who come together, use data, use analytics, change workflows, reduce hospitalizations, reduce unnecessary ER visits, reduce unnecessary procedures, reduce length of stay, deliver better care to patients, save money, and get a piece of those savings. We are now in 20 states. We have about 1,500 full-time primary care physicians. We have $2.5 billion a year of medical spend under management, right? Just goes to show how much need there is out there. And there are tons of folks who are now coming and saying, we have this thing that in a value-based world, we can reduce costs and deliver better patient experience. We want to be in your combustion chamber with you, as it were. And I think that's where we really need more and more places for people to plug in their data analytics, their tools, their behavioral health module, their palliative care thing, their mortality risk adjuster, all that kind of stuff that now we have a need for a whole new ecosystem, right? We had the horse and buggy ecosystem and the bridal shops, and now we have like a car, ecosystem, and now we need, fuzzy dice.
So same question.
We don't need fuzzy dice.
Impact it's made. Give us an example of most recent or a recent kind of example of how Aledade's making that impact.
So last year we got data from official data from Medicare we have 15 groups of physicians, and in 15 out of 15 groups we reduced hospitalizations, we reduced ER visits, we reduced number of days in skilled nursing facilities, and all that translates into thousands of people like my mom who didn't end up in the hospital.
Excellent, excellent. So we're going to open up the questions. Really, fascinating, because I think for everybody here, if the light bulb didn't go off, that the foundation they set up, they're both now practically helping people access the very thing you helped free up.
Is that wrong? Did we do something wrong here?
Well, I was wondering where all the other hands would be up that says, oh, I'm building tools to do just that, because in a sense, it's an open market. And part of the interesting thing is, there's one theory of government where it used to be the case, like some insider sets up some insider thing to do some secret permitting thing, and only the insiders know about it. And it's kind of this Schwabby Washington.
And here we're like shouting from the rooftops.
Like, open, anyone, free, go download,
anyone?
make it happen.
Anyone?
So there's literally no barriers to entry. And I see Bruce is getting lined up. Unless Bruce imposes barriers to entry, Bruce will not. He's tearing down those walls to keep the barriers to entry low.
They built you up a lot, Bruce.
No pressure.
So who has the microphones for questions? All right, questions for Farzad or Aneesh? I can't see. I got a little.
We got one in the back.
Just introduce yourself when you ask your question.
Sure. My name is Vijay Chauhan, and I'm involved with recruiting international innovation in healthcare to the United States.
Can you speak a little closer to the microphone?
Recruiting international innovation. Yeah,
perfect.
So I don't know where you all stand on this issue, but it's widely recognized by digital health companies that the EMR players are a chokehold on innovation coming to the marketplace. What is your sense of that, and where did you all go wrong, if you agree with this, in creating a more competitive environment for the best EMR technologies to come to the marketplace versus depending on one or two players and their market power?
Farzad's going to give you the context, but I'll tell you the punchline. We are tearing down those walls. In calendar year 2018, the hospitals and physician groups are all obligated under regulation, or incentivized, I should say, to adopt open application programming interfaces. So the data that's held by those EHRs have to be made freely available. If the patient invokes their right to access the data, it's a free connection. There's an open regulatory question about whether other app vendors can access it with a similar no friction model. And I will tell you, this is an interesting conundrum. There's a technical component, which is, are you seeing consistency in the publications of these open APIs? I would suggest to you that we're starting to see industry agreement. The Fire API, as constrained by the Argonaut Project Implementation Guide, if you direct it, is at least a toehold in how vendors are certifying their products this calendar year. But more broadly, there will remains active regulatory work to be done. In fact, the ONC, Farzad's old world, he'll comment on this, just published new rules of the road on what it means to be an information blocker in the context of these information sharing networks. And I think there's good news on the horizon, but I'll let Farzad cover that.
What I'll say is, it is extraordinarily difficult. If it were an easy thing, we would have fixed it.
Yep.
And here's the difficulty. You're talking about a market, right? It's like saying, oh, car manufacturers, all car manufacturers should let me put my cassette recorder plug and play into their cars. It is outrageous that all the car manufacturers are preferencing their own proprietary cassette tape interfaces, and I can't put in my new thing in there, right? And they're like, hey, I'm running my business. What gives you the right to put your cassette recorder in my car? Right? I have my partnerships, I got my things going on here, right? So as long as we think about these as technical problems, oh, we lack the technical specifications for the cassette tape interface.
Yeah.
Let's make an open API that would enable you to do that. That's where we were. That's what we thought.
Yes.
We thought this is a technical problem. And we spent a lot of time on technical standards, and then lo and behold, and I just want to caution my brother here a little bit on the open API. Don't be fooled that an open standard API means I can plug in for free anywhere I want.
Right.
Right? I just heard about a startup who basically was like, they went to one of these large EHR vendors and they said, we want to do this thing, we want an API to it. And they said, oh, absolutely, that'll be $5 a call.
Yeah. Yeah.
Is that an open API?
Yeah.
Well, I don't know, right? But then you want the government to come in and tell you that it could be a 32-cent call, but not a $1.32 call? Like, how the heck do you actually do it? Extraordinarily difficult. I have one idea left that I'll give to you for free. The only person who can break that is the patient.
That's right. Free.
You can't
charge $5 to the patient.
You can't charge $5 to the patient. So the only person who can break that is under law, under regulations, under HIPAA, under whatever, is the patient should be able to have a right to get their record for free, essentially, from wherever it sits. If we can make that be real, be true, that could be the, cutting the Gordian knot.
By the way, we're going to make that a free Giphy. You repeating that over and over
Yes.
again. That was awesome.
And Bruce is here to hear it. Woo! That feedback?
Do it, Bruce, do it!
The feedback?
So we have time for a couple more
Yeah.
questions back here. Just introduce yourself.
Hi, Imran Kronk, co-founder and CEO at Ride Health. And like most small startups, we're busy enough running our business day to day. So I wanted to ask you how small organizations can effectively engage with government, with public sector stakeholders, to shape and influence policymaking at a state and federal level, where both we believe it to be intrinsically good and advantageous for our interests.
I was a Virginia Secretary of Technology before I went to the White House, and I will tell you, there are two personas here. For those startups that are dependent on a policy shift, you got to find a path to get right in to bring that idea forward. And thankfully, more and more have clarified what the front door is for new ideas. Like in the Medicare, if you want a payment model change, for example, there's now a formal front door for a startup of a 2-person company. You could help get a doctor to submit a letter that says, hey, I want to test this new idea, and have this physician review panel decide whether they should be a payment trial for it. But the other option is, if you're part of a coalition of the willing, often these things are loose confederations of like-minded souls. And if you care about the piece that Farzad just mentioned, which is the consumer's right to their records to share, I help lead an effort called the Krein Alliance, which allows you to join in a very lightweight way, open working groups, Google groups, et cetera, on what we can do to make the technical, business, and policy-related issues all harmonized to do what he just said and scale it. So either join coalitions or find that one that you want to go deep and find that the innovation path.
Yeah, I would agree. One thing that is a common misconception, I was the regulator, people would hire these big shot lobbying groups, put them on tens of $1,000 retainer, and they would walk him into my office, and I'd look at the guy and say, why don't you just call me? You didn't need that whole thing, right? My number, like HHS directory. Google that.
Bruce.greenstein@hhs.gov.
Right,
Bruce?
And like
Bruce.greenstein@hhs.gov.
And like, you know who reads that email account? Like Bruce.
Bruce.
Bruce. Right?
I'll tell you.
So there is the common perception that, oh, there's all this regulatory capture, everyone's locked away, you have to know somebody. Bullshit, right? People who are there want to hear from people on the front lines. Don't just say, I want this. Everyone says, I want this. That's not information, right? You got to tell me what's actually happening. That you're seeing someone charging you $5 for an API call, right? That's data. That's understanding what's happening in the field, the impact that we're having. But regulators, by and large, want to hear from a diversity of points of view of folks, and the most common thing people don't do is engage with that process. And then again, I understand you're trying to run your business, but healthcare regulations are a big deal for any healthcare startup.
That's right.
So if you can't do it yourself, I agree with Aneesh, find the coalitions, find the groups who are combining their voices, but represent, be there.
So we've got time for one more question.
Esther, we end with the queen. We're not worthy.
Whatever. This
Esther, can you please stand up and
yeah,
also...
sure. This should be a much better question than it is. But it's basically the same question around the Medicare to Medicaid pathway. It's like Medicare does all the cool, innovative stuff, and they fund it because you stay on Medicare, it's stable, whatever. People who are on Medicaid don't stay on Medicaid, but they keep coming back. Just give us some
Federal,
inside
state
perspective on...
Yeah, so many questions, so many answers in this question. States decide what policies they want to advance in Medicaid. And they are, in some cases, copying Control-C, Control-V, the Medicare innovation model at the state level. In other cases, they're outsourcing all of that innovation work to managed care companies, but creating some regulatory vehicle to do that. And in some cases, the federal government's actually specifically working on projects for the dual eligible to see if that can be a way to break the mold. I am personally motivated with the program called the Accountable Health Communities Program, which is a poor carbon copy of your wonderful work in all the communities in which you're operating on the way to Wellville. By the way, if you all want to follow this, follow Esther's work at the way to Wellville. And what I would say to you, the reason I would hug one of the 32 awardees. CMS has published a list of 32 communities that have been granted some money, $100+ million. The money is the least relevant part, but they've got a license to align on data and other policy hooks, so that if you screen people for social determinants of health in the community, these folks have to screen 75,000 people a year. You're going to find out who's got food insecurity, housing insecurity, how often they're on or off Medicaid, whatever the issues are. That'll be part of this screening process. And then there's a whole apparatus to say, how does the medical community tackle those social determinants, and what might the benefits be? Will we see lower public sector Medicare, Medicaid spending on the healthcare side if we tackle the social determinants? So if you hug those 32 communities, you have a vehicle to get policy changed at the state that sponsored it and the feds who've endorsed it. And if and when the new Medicare Innovation Center has hired their person to lead it, that person will be all ears to find ways to tweak, because that's a vehicle that would allow the change to happen.
I mean, I'll just say in closing, thank you, Esther, and the lesson for the rest of us is, let's not forget about the poor. Let's not forget about the disabled. Let's not forget about Medicaid. It touches an enormous number of people in this country. And outside of a few examples, City Block that just got started was the exception that points out how rare it is for us to have startups that actually focus on poor people, the disabled, those on Medicaid. So there is a huge opportunity to do good in the world for those populations. Let's not miss that chance.
So wonderful discussion. I know we could go on, but you've built up Bruce.
I know, he's got no pressure.
I got it.
No
this is all
pressure.
leading. I tell you, we had Bob Kocher here yesterday. Now you two, and then Bruce, and then we're going to see the vice president later this morning, early afternoon. And I want to thank you both for spending time today, but really, honestly, most important, for what you did in 2009, in 2010, 2011 to get us here today. I can tell you from all of the entrepreneurs around the world, not just in the US, from all of the investors and the partners and the organizations that believe that achieving these health moonshots are not possible. Farzad, what you did to go from 9% to 99%, the numbers you referenced earlier, and Aneesh, for you to change people's mindset about how the government can actually shift their mindset and actually begin to unleash and unlock what is all ours already. And again, as I mentioned earlier, you're being the announcer of the launch of Startup Health almost 7 years ago. We said we were going to build a global army of entrepreneurs who were going to transform health and achieve health moonshots. We are 7 years into our 25-year mission, but the work and the foundation you both laid, and you made the announcement on that fateful day. Thank you so very much for today, everything, and what you're both doing now to help transform health.
Thank you. And I hope this was helpful for the crew.
And folks, public service was one of the greatest experiences of my life. If you ever have the opportunity, maybe to work with that guy, jump at it. Do it.
Cheers. Thank you, everybody.
Thanks, man. Thank you, brother.